everybody wants to take their seats, I'm going to introduce our next speaker. Our goal is to stay on time today. We appreciate everybody being here. We also want to be respectful of your time. So our next speaker is Dr. Greg Sachs. He's a geriatrician and an expert in dementia care. He is an investigator here at the IU Center for Aging Research, and he's also actually the chief of general internal medicine and geriatrics here at Indiana University School of Medicine. He's going to tell us actually about one of his studies called In Peace.
I'm actually going to tell you about the journey to getting to the proposed project called In Peace. And it'll start off with really talking about palliative care, because I think what I'd like to get feedback from people on is that talking about palliative care and end-of-life care is actually a touchy subject, and one in which it actually is provides another layer of complexity to trying to improve care for people with dementia and their families. In case anybody from the compliance office talks to you, this is my required slide of my potential conflicts of interest. There actually are no conflicts of interest, though, because none of these things actually have anything to do with my talk. But there it is. So I'm going to start with a case. And this was a 69-year-old woman with advanced Alzheimer's disease, no longer able to recognize her family or perform any basic activities of daily living. And she'd been residing in a nursing facility for 2 years. At that time, she was typically either physically restrained or sedated in order to control agitation or manage her behavior. After repeated infections, antibiotic courses,
I'm getting some signals that we can't hear.
I can lean into this a little bit more. Okay. After many infections, repeated antibiotic courses, and admissions to hospital, she died in the nursing home, restrained, without family around, and with no specific palliative care measures in place. So does that resonate for anybody? Do we still see cases like this? Why was she restrained? Okay, so this case predates a lot of the regulations and efforts made to liberate people from restraints in nursing facilities. It also predates the development of feeding tubes that could be inserted endoscopically, because otherwise I think she probably would have ended up with one. Anything else typical or unusual about the case? Pretty sad, though. So that was my maternal grandmother, and the case is from more than 40 years ago. And when she lived in the nursing facility, it was so upsetting for my mother to visit her that she actually did not allow any of us, any of the grandchildren, to visit my grandmother at all because it was so upsetting. So it's a case that sort of represents, I think, in some ways, some of the worst things that we can do. And it's also a powerful motivator for a lot of the work that I've done. So in my prepared remarks, I'm going to start with talking a little bit about palliative care and how it differs from hospice, talk some about how palliative care may be more challenging in caring for patients with dementia, and then talk about some of the research work that we're doing. So this is one of the more common definitions of palliative care. It's an approach that improves the quality of life for patients and their families when they're facing life-threatening illness, and it's through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And it's a really important definition because sometimes I think when people in the past certainly used to think about, well, it's time to stop doing aggressive care or forego chemotherapy for cancer or other life-sustaining treatments, it was almost like you were stopping doing all the good stuff and you got nothing else in its place. And what the modern field of palliative care is actually saying is that there's a lot that we can do for patients and families, and it's really through aggressive attention to all of these different domains. So palliative care tries to provide relief from pain and other symptoms. It's life-affirming. and it regards dying as a normal process, and we aim neither to hasten nor postpone death. It does integrate the psychological and spiritual aspects of care and is often done in a team approach, like a lot of geriatrics. And it really focuses on where patients and families are at, trying to elicit their goals of care in order to make sure that the care that they get actually matches their goals. Palliative care also can help in transitions, in different types of care and in settings of care. It offers a support system not only to patients but to their families and extends to the bereavement process for families. And importantly nowadays, we view it as something that's essentially appropriate for any phase of a chronic illness and can be given in conjunction with other kinds of treatment, even ones that are directed at cure of an illness. And so you don't have to give up something in order to get palliative care. It should be an added layer of support. So it used to be that in some sense we had people who were sort of living life, and then you were seen as close to death and you got hospice. And the modern model for palliative care is that, you get life-prolonging care, but all along as you have serious illness, you should have palliative care that gets dialed up, as it were, and becomes more and more part of the package. And then hospice care is sort of a specific time and a phase, and palliative care is delivered through hospice. And then caring for families after death is something that palliative care very much embraces. So with palliative care defined and characterized, I'll now turn to just a couple of minutes about why it's more difficult for dementia care. And in some ways, I get to pick on the oncologists because I say that they really have it pretty easy when it comes to figuring out about palliative care. Typically for a cancer patient, when somebody ends up with sort of advanced disease or it becomes metastatic, their course is pretty well defined. They decline over time, and being able to figure out when somebody needs palliative care or even when somebody needs hospice is something that's easier to figure out. Dementia is actually a good example of a chronic disease in which the course, while it has this sort of gradual feel of a decline over time, it's punctuated by these exacerbations. So in dementia, for example, this could be a urinary tract infection, a pneumonia, a heart attack, a stroke, another pneumonia. And some of the things that were sort of easy to figure out up here for cancer are a lot harder. So where are we with dementia in terms of how close are we to the end? It's actually a lot harder to predict. And so to the extent that that matters for decision-making for families and clinicians, it's a lot harder to know where we're at. Any of these points could actually be just like the point up above, in which, depending on the treatment decisions that are made, it could actually be the final events. And because of that, I think it's actually more difficult emotionally and psychologically for both clinicians and families to make decisions about palliative and end-of-life care. Up here, the sort of model case would be somebody who has advanced lung cancer, and even if we put them on the ventilator and they're in the ICU and they're getting all sorts of aggressive treatment, they're going to die anyways. And the treatment is often seen as pretty burdensome. Down here, if we're talking about a pneumonia in a patient with Alzheimer's disease, the treatment is pretty simple. It's antibiotics, even if it's intravenous. It often works. It's not that burdensome. And so for a family and a physician to actually say it's time for us to think differently and to withhold antibiotics is a lot harder. And in fact, I think some people, when they talk about it honestly, will admit that it feels more like they're the actual proximate cause of somebody's death by withholding potentially effective treatment. So I just think it's harder in a lot of different ways. And you're also talking about families making decisions rather than a patient here who's cognitively intact. And certainly making decisions with surrogates, with families, it's always more complicated than just talking with a single patient. All right, so I've set the scene in terms of what palliative care is and why it's harder in the case of dementia. And I'm now going to turn to some of the work that we've done both here and back when I was at the University of Chicago, trying to take the modern model for palliative care and import it into dementia care. And the first project that I'll talk about was called PEACE. And of course, now that I live in Indiana, I could call it In Peace for Indiana version of PEACE. And the notion behind it was, it's really nice. You can call in anything, when you're in Indiana for your acronym. The notion was to try and get palliative care upstream from hospice and from the nursing home to try and provide it to community dwelling patients with moderate to severe dementia and their caregivers. And we wanted to not only integrate palliative care broadly, but specifically advanced care planning, support decision-making, improve symptom management. A big focus, like we have in a lot of dementia care, is on the well-being of the caregiver. We want to avoid burdensome treatments that are no longer helpful in the hospital. And the model that I was learning about as I moved here was the notion of being able to do this as an added layer of support on top of primary care. So the PEACE program, this is what the acronym we came up with for it in Chicago, was originally a demonstration funded by the Robert Wood Johnson Foundation. And our goal was to essentially just show that it was feasible to do this kind of care. And the group of people doing the care were in a geriatrics clinic, so we were all board-certified geriatricians, and many of us actually had an interest in palliative care and eventually became certified in palliative care. So it's a highly unusual group. And because we were the primary care doctors, we actually wrote the orders, we had the relationships with the families and patients, and so it was a little bit unusual. But the results that we were able to achieve at least proved the concept that we could do this. We were able to show, this is just some of the reporting from the interviews with patients who were able to still tell us about their experience and the caregivers. Vast majority said that we were giving the best care possible. They felt like we were treating their pain very well. They had great confidence in the healthcare team, and they felt that we were as helpful as we could possibly be. This is from one of our publications from that demonstration. This may be a little bit difficult to understand. These are odds ratios. And I'll just explain that what we tried to do in PEACE in Chicago was to eventually transfer patients to hospice care. And we compared how people who enrolled in hospice did to people who weren't in hospice. We looked at some of these outcome measures. If you enrolled in hospice, your likelihood of dying in hospital was 1/25th of those not enrolled. So you're highly likely to end up dying outside of the hospital. You're 10 times more likely to die in the location of your choice. The caregiver rated the care as excellent or very good. That rating was more than 5.5 times more likely if you were enrolled in hospice. And if on ratings of pain, even though this didn't reach statistical significance, it was about half of what the people who didn't enroll in hospice. So what we were doing in the ongoing care of patients and supporting them through and getting them to hospice, and about 2/3 of the patients in our program did end up enrolling in hospice, really achieved a lot of the outcomes that people say they would like to have. In addition, we had other kinds of data that we collected from families, from interviews after the patients passed away. And these are the sorts of things that don't often end up in, statistics and scientific journals. But it talks about how important it was that they felt that the team was compassionate, that we supported the decision-making, that we were respectful of the family's opinions and didn't force anything on them. They were attentive to the families' and patients' needs, and they ended up feeling very well supported. So being available, accessible, respectful, and compassionate, things that, probably Nicole tell me that we do have measures for that now, but it's the sort of things that don't often end up being considered the hard outcomes that scientists study. So as I mentioned up front, there are some serious limitations to the demonstration project we did in Chicago. included the fact that it was a pretty unique setting in terms of the providers who were passionate about this specific area. And so you can't really go throughout Indiana and find like how many clinics are there or practices where there are geriatricians who specialize in palliative care. Anybody know of any? I need to know because we'd like to be able to refer people to those practices. We also were doing sort of what our clinicians thought was best. We didn't have it sort of protocolized or standardized. We didn't have a control group, so what I presented to you was just observational data. And we were missing some things that people really nowadays would think would be important in any study of palliative care. So shortly after I moved to Indiana, we were able to get a pilot grant from the National Palliative Care Research Center. And what we were essentially trying to do was take that content from the PEACE program and marry it to the collaborative care model that many people here at IU and IUCAR had been doing, and create an intervention that would be feasible not only to be tested in a randomized trial, but then be scalable and something that we could disseminate broadly. So just a moment on the collaborative care model. So part of my goal, in addition to getting feedback about talking about palliative care, would be what we're talking about doing in our next study is this added layer on top of whatever people are getting for their primary care. And so one of the challenges that we have is that we want to be able to enroll people from multiple health systems. And we want to reassure them that we're not going to steal their patients. So the goal isn't for them, if they're getting care at Community or St. Vincent's or somewhere else, isn't to end up having them come to us at Eskenazi or IU, but it's for us to be able to project our additional expertise and support to that practice and those patients and families. And so the collaborative care model here has been for many studies done by my colleagues at IU to treat depression, frailty, dementia, sort of earlier stage, pain and depression actually outside the elderly group. And it's generally a combination of some kinds of providers, care coordinators, a team that essentially helps review care and then projects this plan of proactive assessment and management into patients and families' homes. And we have standard assessments, standard protocols, and then we loop back to the primary care physician so they're part of what we're doing. But we're helping to do things that they wouldn't otherwise be able to do. And then we track the results in a very iterative fashion. So if you remember that earlier slide that I showed about palliative care and how it now, if you just start inserting some of the things from dementia care, this is dementia care as we now do it, and now dialing up the palliative care stuff that we learned from the PEACE study. And so literally what we're combining are some of the things that we've been doing based on earlier studies in IUCAR about protocols for treating these different kinds of conditions and issues. We carry those forward into PEACE, but we now add some specific ones about pain, symptom management, feeding difficulties, advanced care planning, hospice, and navigating the acute hospital setting. And with that funding from the National Palliative Care Research Center, we were able to do a small pilot with 15 dyads of a patient and caregiver. And I'll just draw your attention to this number. The mean mini mental state score was actually under 10. So we were aiming for people with more moderate to severe disease living in the community still, not within nursing facilities. And some of the early results where we're in a pilot, we're really trying to show, can we actually do what we said we were going to do? And is there any signal that we're already starting to have some beneficial effects? This NPI, Neuropsychiatric Inventory Questionnaire, is something that's used even in drug studies for antipsychotic drugs, but was also used in Dr. Callahan's PREVENT study and others. And basically, the higher the score, the more symptoms people are having. And in many studies of antipsychotic medications, going from 1 score down by 3 is actually considered a very positive result. The PREVENT study that Dr. Callahan did actually reduced those scores by as much as 5.5. And there's both measuring the symptoms in the patient and the effect or the burden on the caregiver. And for both of these, we were able to show that we were already starting, even with just 15 subjects, things were moving in the right direction. So this is the kind of preliminary data that allowed us to submit a grant for a more definitive large trial to NIH. So we're waiting, and that grant proposal actually was already scored and got a very fundable score. For those of you who are familiar with the arcane work of the National Institutes of Health, there are multiple steps, and it takes a lot longer, contributes to the 17 years of why it takes to get innovations out there. But actually next week is what they call their council review. And hopefully after that's done, we'll actually get a notice of award and be able to start doing the study. And our specific aims are to try and improve the neuropsychiatric symptoms in patients, improve other symptoms, see if we can also help at the same time to be lessening the impact of those kinds of symptoms on caregiver distress and mood. And then see at the very end if we're able to have an effect based on advanced care planning, goals of care conversations, to help people avoid burdensome treatments that come from hospital admission and emergency room visits. So those are the things we're aiming at. And we're going to be seeking to enroll 200 pairs of patient and caregiver. 100 will be in the intervention, and 100 will be in the usual care or control arm. They have to be community dwelling, as I've already mentioned. We don't want to have to evaluate patients in the sense of assigning a diagnosis, so they need to come from a practice where they've already essentially been assigned a diagnosis, and where the collaborating physicians are willing to let us get at some of the medical record information for that. And we're going to follow people once they're enrolled for 2 years. And as I've already alluded to with what the work we did in Chicago, it's going to be a team of people, especially a nurse and social worker, who are connected with the other clinicians. We're going to proactively assess symptoms and help manage both patient symptoms and caregiver distress. We'll have evidence-based protocols to essentially get triggered by the needs of the patients and families. We'll focus as well on advanced care planning and decision support. And we'll have a lot of materials and processes to help educate and support the caregiver in the home so that they're able to continue providing this kind of care. So compared to other aspects of dementia care, I would say that less is known about palliative care, especially in the community setting. I've reviewed some of the reasons for why I think it's especially challenging. I think we've shown that it's quite possible to provide excellent palliative care to people with dementia, and we're keeping our fingers crossed for next week. So where we should end up, hopefully, is that rather than the kind of case that I described that my grandmother sort of identified for us, this was another case from the Chicago experience, an 85-year-old gentleman with advanced Alzheimer's, living at home with his wife. During the last 3 years of his life, he was only hospitalized once, and that was after an infection, dehydration, and a fall. After that, as his care plan continued to shift towards more of a focus on palliative care, when he developed a pneumonia, he was enrolled in hospice. He died comfortably at home, unrestrained, no feeding tube, and with his family around him with his symptoms well controlled. So that's what we're aiming at in a more concrete way. And then I think we now have about 17 minutes left for comments, suggestions, questions.
So what happens today if you go to the hospital with somebody with a chronic condition, or you're seeing your physician and you say, by the way, I'd like a palliative care consult. Is that even, will people really understand what the goal is to support the chronic care? Or will that be like really out of the box for people at the moment, do you think?
Excellent question. I would say that fortunately nowadays, palliative care, especially in our region, you can get a palliative care consult at most hospitals, and certainly in most of the major hospitals, they have well-established palliative care consultation teams. So what we can have people learning about is, even if the treating physicians that they happen to be bumping into, like a hospitalist, let's say, isn't familiar with it, that there are expert people and they can ask for a consult and they can get it, which is very different than how it was 20 years ago. Now, whether or not the treating physicians in the hospital are well educated about palliative care and when it's appropriate to consult, I think is still a work in progress. So you can get people who regularly refer to palliative care, and there are some clinicians where they would still need to get the basics about the definition and understand what it is.
I have a question.
Okay.
I have a friend who just this weekend was at the hospital with her father, and she asked for a consult on palliative care. And she said two things happened, that the lady that spoke with her, the case manager, was really informative. But she said two things to her: that the ER doctor should not do the referral, that she should go to the family doctor in order to get the payment for the palliative care. And then the second thing was that she told her to be aware that once palliative care started, that they would start talking to her about hospice care. So I was just wondering, is that really the case, or is that what they should expect from as a family?
So the two parts of that, one would be, I would say that occasionally emergency room physicians make referrals directly to hospice. Those often are instances where things are sort of clear cut in terms of where the patient's at, what their prognosis is, and what the family and patient are aiming at. I would say that that still is appropriately unusual in the sense that an ER physician doesn't really know these people in general, unless they've been there frequently. And so I would have greater confidence about a referral coming from the primary care physician who knows the patient, knows their overall course, and can put it in the context of the overall illness. It's interesting. I think there are still a lot of misconceptions out there about palliative care, and that's why I spent some time about what it's supposed to be. There are people who, even on palliative care listservs right now, where I'd say every several months to couple years, there'll be a conversation about, well, should we change the name? Should it be called supportive care? And why is that? Well, palliative care is sort of seen as being linked to hospice care. And so then it all gets sort of seen as it's the stuff you do at the very, very end, as opposed to this modern notion that it should be done upstream. And even the American Society of Clinical Oncology, the cancer docs, say that palliative care should start at the time of diagnosis. So I think there are still people out there who think that palliative care is just about the very end, and that you will necessarily be referred from palliative care to hospice. Now, in a specific case, that might still happen, and it might be appropriate depending on the needs of the patient and family. So if the patient has less than 6 months to live based on the best estimates, if there are a lot of unmet needs, and there's a clear desire to focus on comfort care, then the palliative care team might in fact make a referral to hospice. So I think a lot of it will depend about the specifics. But whenever I hear the story that you told, I worry that it's part of that still misunderstanding or misconception about what palliative care is supposed to be. Was it right?
I always have heard that Indiana in specifically, but then just generally, that people are late in making use of palliative care or hospice care, that usually you hear that about somebody and it's a day or two before they're gone. Is one of the measures in this, in looking at this effort to encourage people to use the palliative care services sooner, and is that a goal of the project, or is that an outcome of is that people are using the services sooner?
Yes, so we definitely are trying to demonstrate that by using a palliative care approach earlier and not waiting till people are eligible for hospice, that we're able to provide good care for a longer period of time and achieve better care in a lot of the measures that I mentioned. Nationally, we do a pretty poor job, and I don't know if Indiana is that far off from the average, because the national average for length of stay in hospice has been hovering around 20 days for the last several years. And that's where the hospice benefit says that you have to have a likelihood of dying within 6 months. So that means even if you have people who are there for many months, or even were wrong and they live longer, we do have a big chunk of people who get referred to hospice in their last days. And in some studies, it's as much as like 15% in the last few days of life. And hospice folks will tell you that they're not able to do as good a job when they get this sort of last minute referral. They are scrambling to get, equipment into the home. They're getting to know the patients and families. They're getting medications ordered. And they don't have a chance to have relationships with the patient and family and to really get to know them and understand their needs. And so I think in general, there's a desire both within hospice and within the broader palliative care community to sort of get upstream and get to people earlier to provide this kind of care. Absolutely.
Related to the question about earlier and upstream, in the case of dementia, what's your experience in particular with families introducing palliative care when the trajectory of dementia is so extended and can sometimes be so slow in the changing that it's really difficult sometimes for families to even see how severe the person is in their disease process?
So that's an excellent question, and I'll say I'll agree completely with the premise, which is it's yet another one of the challenges, in a sense, for providing palliative care in dementia. So I'm not going to start talking about feeding tubes and end-of-life stuff with somebody with mild cognitive impairment, right? It just doesn't make a lot of sense. Where we'll start the conversation is around advanced care planning and sort of goals of care. And then we'll set it up as something that's going to be a recurring conversation over time. So right now, they don't need a lot of services or they don't have a lot of unmet needs, but I want to know if they have a sense of what their goals and preferences are. Make sure they've designated a healthcare representative, so when the patient loses the ability to tell me what they want, I've got clear ideas of who's going to be making decisions and what some of those might be. And then that becomes something that is a recurring conversation over time. And the way that we've in fact set it up in the protocol for In Peace would be that a rediscussion of goals of care and advanced care planning needs to happen when there are major steps down in function, when people have been to the hospital, or when they start to have feeding difficulties or losing weight. So it should be this sort of recurring conversation over time. And I think when it's approached that way, and you can actually, as a patient gets sicker, you can start to foreshadow and talk about the kinds of things that may be coming down the line. So a good example of that would be, so if I have a patient who is very frail and losing weight, I'm going to start talking about those challenges and what we can do and what we might not want to do, like we avoid feeding tubes in advanced dementia. And so I don't wait until like they're in the hospital and somebody's talking about a feeding tube. We start talking about it a little bit further upstream and say, it's not something we need to decide about today, but this is something along with other kinds of difficult decisions that we're going to get to. And I think when it's done that way over time and you've been able to develop trust with people, it's very well received. Because that's essentially what we did in the Chicago program, and I think what we've carried forward with some of our practices already, even without the trial.
Our experience has been that up until the last few years, the dementia community of interest tended not to relate to dementias as terminal illnesses. Alzheimer's Association for years didn't post this as a cause of death. I've actually been questioned in the past by coroner's office about listing Alzheimer's as a cause of death. So although that's clearly changed in the last few years, both at the provider and at the patient side, our experience is when you start talking to people about this as a terminal illness, a very high percentage of them, including physicians, by the way, are surprised. Even now, I would say over 50% of the patients' families or caregivers that we start talking to don't have a clear understanding that this in and of itself is a terminal disease.
Yeah, no, I think that's a great point. And I would agree with you that we've been making progress on that. Both the National Alzheimer's Association and the Greater Indiana chapter, I think, have been much more in tune with palliative care. The Indiana chapter annual education conference was just last Friday, 2 Fridays ago, and I gave a talk about palliative care. So the National Association actually has had white papers on this subject and has information material. And so I think we have been moving in the right direction. The other thing that I think it's interesting to think about is how important is it to get clarity about it being a terminal illness? So this is where sort of the national discussion about palliative care, that if you talk to some of the leaders in the field, they'll sort of tell you that, probably about 15 years ago, they sort of realized, trying to get people to understand what a terminal illness is and to embrace death and dying as part of life was a losing battle. It just wasn't getting a lot of traction. Nobody wants to die. So we tend to, sort of push back or, resist conversations about that. So the shift to saying that palliative care is something that everybody with a serious illness needs. And in fact, the Center to Advance Palliative Care did some market research on this that basically showed that at the time, the vast majority of people didn't know what the heck palliative care was. But if you described it to them and described it as being something to do the things that I mentioned at the beginning for anyone with serious illness, all the people in that market research said, yeah, I want that for me and for my family. So there are some ways in which moving away from that debate about whether or not it's a terminal illness can actually be helpful. Because then the oncologists have actually done this too, because they're, by sort of saying it needs to be there from the beginning of treatment for people with advanced cancer, that you can do it at the same time as you're getting chemotherapy, all of a sudden it's something that people want. And in some palliative care programs around the country now, our problem isn't like, it used to be with knocking on doors and getting people to open up and listen to us. We're now being overwhelmed by the number of patients who need us, and we don't have enough providers. So I think there's some ways in which I'm with you, and I would argue that dementia, Alzheimer's disease, is a lot like cancer, and that it just goes over a longer period of time, but it still is a progressive, irreversible condition. But I also think that avoiding that debate may actually get us more mileage. That said, when I talk, at least with our current armamentarium of drugs for treating Alzheimer's disease, when I talk to families about what those drugs can do, I hold my fingers up like this and I say they help this much. And I'm very blunt about saying that it doesn't reverse the disease, it doesn't stop it in its tracks. And there's debate about whether or not it changes the course at all, and that people will get worse over time despite the best medical care. So without using the word terminal, I do use words about progressive and, and other ways of talking about it, so that I'm very clear about, even from early on, that part of what we're doing is we're going to be with people through this journey over time. And it's not something we're going to fix. I also have a funny story from a paper that we published, I think 2004, where we were writing about the barriers to dementia care, palliative care and dementia. And we actually got into it with the editors of the journal because they didn't want us to say that dementia could be a terminal illness. But that was 14 years ago, so I think we're a lot better off, but it's still a work in progress for sure. Okay.
So I love the fact that we could call it supportive care. I think it is very supportive in the continuum, but cancer tends to have a start point. I work a lot in chronic disease, heart failure, and COPD management, and so there's that progression into that disease process. How do we change the culture to get those questions that you do so well asking about the goal setting for the patients? How do we get that ingrained to ask those questions at the start of those disease processes?
Wow. If I knew how to do that, I wouldn't need this grant. No, I think that there are a lot of people, and when I gave the talk to the Alzheimer's Association folks, there were like 5 different slides that I had on different resources for starting conversations. There's actually a lot out there, and whether it's stuff through Respecting Choices, or the Serious Illness Conversation Project, or 5 Wishes. I mean, there's just a lot out there now. Some of it is for training physicians and other practitioners. Some of it's patient-facing. Another favorite of mine is work by Rebecca Sidori. She's got a website. If you just Google Prepare, prepare.org will come up, and it's her website that's how to help patients and families prepare for having these conversations. So there's a lot more out there now, and I think there was a grant from, I'm trying to remember which organizations, was it Hartford? To a number of these different groups, and even the Vital Talk group, about trying to pull all their stuff together so that they're not really like competing, but trying to figure out ways that they can all together be helping to support the push to have both clinicians and patients and families educated so we can get them together to be having conversations. Thank you.
So Dr. Kathleen Unroe is going to be our next speaker, and she's going to come up and pull up her slides on the story of optimistic and collaborating with partners. But while she's doing that, I actually wanted to take a minute to thank, we actually have had some sponsors for this event. I think first is IUCAR. As I mentioned earlier, they committed a pilot project to start to investigate new ways to engage the community. And so you're sitting in a room that's part of that pilot. So thank you for the leadership of the Center for Aging Research. Also, Home Instead Senior Care helped supply the breakfast along with University of Indianapolis. So thank you very much to our sponsors for the breakfast. And lastly, I'd like to thank Jaleesa King. Look at that timing. It was perfect. She's walking up right now. She did the lion's share of putting this event on for everybody today. So I'd like to kind of take a minute to thank her for all of her hard work. And then we're going to have Dr. Unruh, and we'll actually have a few minutes for some questions at the end and some final remarks, and then we'll send you on your way.